Hi, everybody. This is the review session for the exam that you'll be taking Tuesday at 11. So I will cover, and some of the things that were in some of the other lectures I sent you, I'll try to cover all of those in this perhaps 40-minute or so presentation. We start with skin diseases. Remember, the topics are skin, respiratory, wound, and lastly, genitourinary or sexually transmitted infections. So with regard to the skin, it's all about Staphylococcus species, particularly Staph aureus and Staph epidermidis. Yet everything can be a cause for skin infections because there's any number of items: bacteria, viruses, fungi, yeasts, a variety of protozoans, anything, because once the skin is violated in some way, a scratch, a hair follicle or something like that, that's any type of opening in the skin sort of paves the way for this to occur. The difficulty, particularly with the most common problem that we face, which is Staphylococcus aureus, is that it is, while it's easy to identify, it's very hard to treat. It grows very, very easily, particularly on the skin, because the skin is so salty, and it actually likes salt to grow. But it has a tremendous amount of resistance to antibiotics, particularly because we use so much penicillin that nearly all strains now make something called penicillinase of some form or another, which you might remember from the last exam was either beta-lactamase producers or penicillinase producers. Now about 90% of them make that. They're not an endospore former, so there's nothing unusual about them in that regard. They're not acid-fast. They're a gram-positive cocci. But really the significant feature is trying to deal with them with regard to antibiotics, and we're really running out of choices. The staph for a relatively simple-looking microbe, is a very, very complex microbe with regard to how much it produces. So many different enzymes, so many different factors, so many things that trigger the immune system. Particularly, coagulates would be number one. That really distinguishes it. It's something that coagulates plasma and sort of walls it away from anything that's trying to treat it. It has a variety of toxins, toxic shock toxin. It produces, these are all exotoxins. It's called a skin syndrome, is caused by a toxin known as exfoliatin. It causes the most common children's skin infections, which is called impetigo, which is typically forms with a pustule or maybe a blister that opens and weeps sort of a golden yellow pus, and then it's kind of dry and crusty. You see it all the time in kids, typically close contact. It can be staphylococcal, and sometimes it's streptococcal, because the other big player in this with skin infections is Streptococcus pyogenes. So I'd say 90% are staphylococcal, and then we start to get to some of the other things from contamination. Streptococcal, because it's so commonly in our throat, and we have some organisms that end up on the skin, coughing and sneezing and the like. And again, children more so than any others, they don't always cover their hands or wash them and things like that are there. So impetigo is really significant. So when it's caused by streptococcal agents, it can lead, and with some degree of frequency, it's surprisingly, because it forms big immunological clumps that clog the kidney. It's called acute glomerulonephritis. That's there. And with the staphylococcal, you can get scalded skin syndrome, as I said before, conceivably toxic shock, though it usually requires an unusual wound, or we're seeing it now more like a wound infection from someone who's trying to inject themselves, like say with a bodybuilding drug or some inappropriate needle injection type stuff. That's there. Viruses are extremely common, and warts are certainly number one. The HPV, human papillomavirus, is by definition a disease of the skin. It isolates itself in what's called the stratum granulosum, which is something you may have learned about in anatomy and physiology. One of the layers of the epidermis, the outer layer of the skin. The good news about streptococcal infections is they're much less difficult to treat with antibiotics. For years, basic penicillins worked great, but we're beginning to see more resistance. You don't have to use broad spectrum agents. Again, the allergies are really the only thing that limits you. You don't have to use combinations or anything along those lines. It's in general, Organisms that are hard to grow, like Streptococcus, are relatively speaking easy to treat. The other category of fungal infections are yeast infections, and we see this on the skin a lot, and that's Candida. This is real, think diaper rash, number one. Candida albicans because it's white when it grows, and sometimes when we see it in urinary tract infections and vaginal yeast infections, there's like a white kind of pigmented drainage, but it's a really common problem. There's other yeasts that are on the skin and fungi that are on the skin, and that's where athlete's foot and jock itch and problems with underarms and the hair and the beard, they're all called tinea, Tinea infections. And by and large, there's a lot of factors. Some people are hereditarily prone, hygiene plays a role, allergies plays a role, and where you see it the most is where there's moisture, because moisture on the skin breaks it down. From skin under the arms, in the groin, where there's a lot of hair, areas where it's oily. Those are people with glabrous skin, that skin that kind of overlaps somebody's very heavy. Those kinds of things are where that moisture begins to break it down. And that's really a lot of the treatment is the moisture and dealing with the hygiene and weight loss and all of those things. Collectively, we call a lot of these tinea, Tinea, like tinea pedis for athlete's foot, or tinea barbae for beard, or tinea cruris, crural area, because we're referencing the groin in that regard. So that's another important area that we have to look at, and with regard to those things. So those are all very, very common infections that we see. A lot of times we classify skin infections based on where they're basic, where we see or they demonstrate themselves with regard to signs and symptoms. And that's where chickenpox and measles and German measles, so chickenpox, varicella, measles, rubeola, German measles, rubella, those are all by definition skin disorders, even though they principally start respiratorily, but the damage that the virus does when it gets into circulation creates irregularities in the skin. So the cells that they impact either cause drainage and cause pigmentation, little spots like the measles or German measles, rubeola and rubella, or actually to breakdown of the skin and the formation first of little tiny pustules, and then that begin to break. We call them pox because they have little dark areas that come to it, little scabs that form. And pox was short for pustules or pox-forming diseases. So chickenpox or varicella is a herpes virus. That's a very famous varicella zoster virus because the end play of it, when it recurs, it doesn't look like chickenpox at all. It looks like something totally different. It's a much angrier looking rash that's not all over the body, but follows a dermatome, follows the root of a sensory nerve in the skin, because that's where the virus hides out and becomes latent. It's really the poster child for latent viruses. And it's very angry looking. And about 1/3 of us get shingles, even though there's some immunizations. It's still, it's very hard, difficult to treat, very, very painful. So those are other things that you have to be sort of wary of or aware of. Again, red measles are known as rubeola because they were ruby colored. That was typically the way that they were looked at. And with all of these infections of the skin, whether they're viral or fungal or yeast or any agent that damages the skin, what you really worry about is secondary bacterial infections. The bacterial infections have a much greater possibility of creating damage, getting into the bloodstream, going into the bone. So really that's a lot of the problems. And the same is true for respiratory infections, where a lot of times viral respiratory infections are comparatively mild. I'm not talking about the coronavirus or really severe influenza viruses, but a lot of times it's the secondary bacterial infections that are life-threatening, more so than that. Rubella is a very mild skin infection that starts respiratorily. We call it German measles or the 3-day measles, because the old red measles were 7-day measles were rubeola. The big problem is it crosses the blood-brain barrier and is particularly damaging to the unborn child, causing mostly sensory deficits, particularly hearing. And really, from a standpoint of transmission, nothing is easier to transmit than warts, which are a naked virus, can be sexually transmitted, any kind of physical or close contact, or precancerous or cancerous lesions, awful. As we move on to respiratory, understand that the respiratory has the greatest number of agents that infect us. And I don't go too crazy on coronavirus because at this point, there's so much out about there. Maybe, 10 years from now, as we begin to study and see what it actually does, we comment on it. Really understand what happened. So the respiratory is a very interesting system because it's a shared system, oral and respiratory, in your mouth and in your nose, mouth for both, nose for breathing, and involves all manner of normal flora. I mean, you'll find everything there, literally. Gram positives, gram negatives, rods, cocci, aerobes and anaerobes. There's so many different ones. So it's really vast, and you should review the different species or categories or groups of respiratory flora that are there. The one we hear about the most, and probably the most best known, is the strep throat, which is short for streptococcus infection. And it's caused by group A, beta hemolytic Streptococcus pyogenes, or pus producer. And the big problem is not the damage it does to your throat, it's all the immunological complications, because it generates real profound immune system activity. It can even lead to toxic shock or things like that. That's another offshoot of this. It produces, these are made either by exotoxins, and these toxins tend to generate immune activity that can cause those big immune complexes that clog the kidney, glomerulonephritis. They can cause, most notably, big toxins that activate your immune system that cause scarlet fever, which has vast number of problems, or toxic shock, vast number of problems. And the one you hear about perhaps the most historically was rheumatic fever, which caused a lot of damage to heart valves. The antibodies would attack healthy tissue in the lining of joints and in the lining of heart valves. And so that's where the name rheumatic came from. The joint problems that were called rheumatic arthritis or rheumatic fever, because of the immune system, there was a lot of febrile components to it as well. Very significant. So other than the heart valves, it could occur anywhere, and rheumatic fever, it was a big cause of death before the advent of penicillin, because it was very easily treated with penicillin. But again, most of the activation is the activation of your immune system. So things like scarlet fever and toxic shock classify as what are called super antigens, because they cause a vast outpouring of what are called cytokines, which are those toxic, not toxic, but immune system chemicals that trigger masses of inflammation and gobble up a lot of the resources your body needs to heal itself somewhat ineffectively. So that's sort of the general look at the common ones. So streptococcal pharyngitis or strep throat pharyngitis is just simply a sore throat. So these, and from an upper respiratory perspective, there aren't a lot of them that are dangerous, but one that we're immunized for is called diphtheria. And you might remember me telling you about that. Very scary, because diphtheria starts as a common cold, but in many individuals, the toxins, and it's an AB toxin again, that's a protein toxin. What it does is it can cause damage in other areas like your heart or your nervous system. It can be very, very painful and life-threatening. And more importantly, it causes damage to the throat, and it causes a clumping, or what's called a pseudomembrane. It's almost like a mass of peeling off of the lining of your throat that clogs and makes it unable to breathe. And so that's really the characteristic thing, that you see a gray-white membrane in the lining cells, the epithelial cells of your throat, and it's extraordinarily difficult to breathe, and then painful, along with aspects of heart, kidney, and nervous system. And without unimmunized people probably die 10% of the time, and the others become very, very ill. So it was one of the early immunizations, along with pertussis, which we'll get to in this unit, which is whooping cough, and tetanus. That's the classic DPT or tetanus shot that people are so commonly receive. Maybe after strep throat, the most common kinds of bacterial, both viral and bacterial infections, are ear infections. And these three are all married together because they all sort of stem from and use the nasal cavity as a passageway in or out. And they're conjunctivitis, pink eye, middle ear infections, and the standard sinus infection. About 1/3 are viral, about 2/3 are bacterial. Two main organisms cause these. both of which can be found normally in our throat on numerous occasions. And they are, because they're part of the normal flora, and they are Haemophilus influenza and Streptococcus pneumonia. So H. flu and strep pneumonia both are common organisms that are part of normal flora. Haemophilus influenza is a gram-negative, relatively easy to kill. Streptococcus pneumonia is a gram-positive, relatively easy to kill. And that's where amoxicillin has got all that usage. It was developed here in Pittsburgh at the Eye and Ear Hospital, most of the research about that, and still used extensively today, because ampicillin, one ingredient in amoxicillin, would be fairly easy to take care of both of these most of the times, because typically they did not produce the characteristic beta-lactamases. If they did, then they would move up to augmentin. And again, for people who could not tolerate the penicillins or were allergic to them, then you ended up using something like a Z-Pak now, or an erythromycin derivative. All those systems are linked with passageways to and from in the nose, particularly the eustachian or auditory tube. That's the big tube that goes to the middle ear chamber from the back of the nasal cavity. That's there, known as the nasopharynx. And that's how it transfers. And that tube is very interesting anatomically. It's very, very horizontal in babies and gets steadily pointing more downward as we grow older and as we physically mature. So as our body changes, we're much less prone to these. But when babies are sleeping, the drainage from these nasal infections goes right back and frequently gets trapped. So even though the initial treatment is oral antibiotics, very often when there's repetitive infections, and there's a lot of additional factors that are involved with it, everything from long-term use of pacifiers, different organisms making biofilms, people who are hereditarily prone to it, other kinds of damage or conditions that are there, then the treatment has to be to open these, allow drainage, basically, to let the infection, because the eustachian tube is too narrow or irritated, and that's where ventilation tubes come in. And that's when you hear about tubes in a kid's ear. That's it's a little rubber tube with a hole in it called a ventilation tube. And inevitably, either you had them yourself or you know somebody who had them as well. So that's something else to mention. Certainly the most common problems are upper respiratory infections, and none more common when it comes to viruses than the common cold, which, if you hear my voice, I have one probably right now. And most of those times they're caused by a rhinovirus, which is in the pico-RNA virus category. There are other things that can cause that kind of a virus, okay, that can lead to colds, even some mild forms of coronaviruses and adenoviruses, but by far and away the rhinovirus is number one in the hit parade. Not much to say about it. Most of it's immunological, like I have now: runny nose, scratchy throat, clogging, congestions, and most of those are immune systems, inflammatory changes that are occurring in the upper respiratory area. But big problems are when we have lower respiratory infections. That means you're getting into the area below the larynx. Maybe laryngitis, if it starts there, would be part of it. The larynx is sort of the anatomical divide. And so you're getting trachea, bronchi, and the lungs themselves. And when fluid accumulates in the lungs and you can't exchange oxygen and carbon dioxide, now you have bacterial pneumonia. And pneumonia is real. Now you have pneumonia, and bacterial pneumonias are a lot more damaging and devastating. And interestingly, it's that same one you heard about before, Streptococcus pneumonia, even though a lot of us harbor it normally in our bloodstream, or rather in our nasal passages. It doesn't mean it's going to hurt you. It just means it's there. And frequently, if there's irritation to the lung, someone's a smoker, someone's had a viral agent that caused lung irritation, some type of allergic phenomena, now they're predisposed to bacterial pneumonia. And that was one of the things that would occur with people who have had coronavirus as well. Pneumonias have a lot of signs and symptoms: fever, pain, difficulty in breathing, blood-tinged sputum, because if it's damaging the lung, and the lungs are in intimate contact with the bloodstream to exchange oxygen and carbon dioxide, you get blood in the sputum. That's very, very common. Cough, fever, chest pain, all of those. Most of these organisms, particularly the bacteria, have capsules. The capsule makes it difficult to gobble up by your immune system. That's really a significant factor. Tuberculosis, which is a kind of pneumonia, is in this category. Streptococcus pneumonia, the ones that are dangerous to us are the ones that are encapsulated. Klebsiella pneumonia, most of them are in this category. And we'll even see pneumonias caused by fungi and yeast, and most of those are encapsulated. One that's named pneumonia, but not quite as severe and not quite as damaging, but lasts a long time, is called walking pneumonia. It's caused by something called mycoplasma pneumonia. Mycoplasma are interesting. They're oddball bacteria that don't have a really organized cell wall, and therefore those bacteria are, how should I say it, more difficult to find than antibiotics sometimes. So penicillin agents don't work. The Z-Pak does work well. They take longer to develop. The symptoms are not as bad. The fever's not as high. You can function better. You're not sick in bed. And that's why they call it walking pneumonia. So it's college students, people in the military, kind of work God's name. Now, a lot of times in the old days, before we had the immunization, they had whooping cough, which was really severe in infants. That's another bacteria, and again, it damages that mucociliary escalator, the lining in the throat going into the trachea, causing an accumulation of mucus, making it very difficult to inhale. And when they would inhale, they'd make that sort of whistling, distinctive sound, trying to suck air in, called a whoop. And the name of that disease was known as pertussis. Okay. So the actual name of the organism is called Bordetella pertussis. And if you know about Bordetella immunizations, that's something that they give to dogs if they're going to be in a kennel from kennel cough. But this one is called Bordetella pertussis. A lot of us have had this as adults or older children, where it's a lingering cough that has to be treated by antibiotics long term. We're just starting to notice that now more over the last 20 years. So there's, and of all of the immunizations, I would say this is the least effective consistently, where diphtheria and tetanus are very, very effective. The P part, the pertussis part, is not. And again, it's bacterial, not viral. Again, it's an AB toxin, so that's where toxoids come in. Legionnaire's disease, we all thought it was a recurrence of one of these dreaded pneumonias, like the dreaded flus, like the Spanish flu. It killed 100 million people, let's say, in 1918, that you hear about so much today. But what happened is it really was an odd situation. It's an environmental bacteria that flourishes in old and water environments, moist, dank, dusty environments, older buildings. And basically, it's a bacteria that grows. And it got its name because it first affected an American Legion convention at the Bicentennial in Philadelphia in 1976, hence the name Legionnaire's disease. They thought it was viral, but found out subsequently that it was a very hard to cultivate bacteria until they went into the ventilation systems in these rooms at all of these Legionnaires. And it's really acted like a very severe influenza outbreak, and the fact that people got quite sick, had a lot of pain, breathing, gastrointestinal symptoms. It's not so severe. Unfortunately, we've had some outbreaks with bad water systems, and one in the VA here in Pittsburgh. And really that just goes to some significant problems they have with the Veterans Administration and the way things are managed and taken care of. It's tragic. Nevertheless, it's not nearly as fatal in young, healthy individuals, but those American Legion folks were mostly older, and many of them had a long history of men of that age group did, of smoking and alcohol, which really was an additional factor, what we call a comorbidity. Now, as we begin to move on, we'll see some other things that are there. Influenza. Really, we hear so much about it, and this is flu season now, and a lot of people are going to be getting tested for COVID and find that it's negative and still feel lousy, and it probably means they got a flu. Okay, and because it has all of these fever, pain, weakness, sometimes it'll work its way into the gastrointestinal. You feel very lethargic, very tired. Balance is off. I mean, you're really, if you want to use the term, unfortunately my dog is out being groomed, sick as a dog. That's there. It's not a short illness. You're generally down for a week, and it probably takes another week to 10 days to feel better and get back. It is a seasonal problem because this particular virus mutates frequently. It's called antigenic drift. It's a subtle mutation that renders changes so your immune system can't work as effectively, and vaccines don't work as effectively because it's constantly mutating. It's one of those interesting RNA viruses that has the 7 to 8 single strands that we had talked about in viruses. That's called antigenic drift. When you hear about the Spanish flu or the bird flu or the swine flu, that means there's been an interaction, usually on a farm, or what we think happened with coronavirus in one of these open air markets where all these species were, in the process of being sold, slaughtered, etc., where you had a mingling of viral particles from different species at the same time, creating what we call a novel, N-O-V-E-L, or new virus, one we hadn't seen, with these oddball antigens. That's called antigenic shift, and it creates something that your immune system can't combat very effectively and is usually extremely severe. And again, viruses, it's usually your immune system. It almost spikes it into an overreaction and causes unusual changes when it bonds to certain cells. So nowadays, influenza, take it for what it's worth, the CDC recommends everybody gets one. It used to be just people over 50 or 60 and people in healthcare or at-risk people or people with respiratory problems. But now the recommendation is global. It's your choice. There are other infections that we see. The most common in the newborn, particularly preemies, is called respiratory syncytial virus, or RSV, a paramyxovirus that we had talked about previously. In adults, it causes something. It's another one of these whistling sounds, but it's more an exhale and sounds a lot worse than it's called the croup. And my kids had that, and it's scary for a parent, but thankfully it goes away. And nowadays with those cool mist humidifiers, that has really helped a lot. When the kids had that tendency and you ran those in the room, they were much easier to use, those ultrasonic humidifiers. Tuberculosis is a disease that's, again, one of the, along with measles, on the poster child for re-emergent or resurgent diseases. And that has to do a lot with overcrowding, immune suppressants, people not being treated for it, almost people not being screened for it as consistently as they should be, though most of it, anyway, healthcare, we would certainly be screened on a consistent basis. And it's classically a wasting disease. It almost acts like lung cancer in the sense that this disease can spread anywhere. It forms in your lungs. It forms cavities in your lungs. The cavities break down, and inside those cavities are these tubercles, these nodes of bacteria that are growing and spread directly into the bloodstream. So they can go to bone, they can go to organs, they can go anywhere. It's called Mycobacterium tuberculosis. The problem is it's airborne. Now, it isn't a droplet. It stays in the air. And so we have to be very careful when someone has known disease, with a lot of precautions and protective equipment for that. And it's highlighted by that, when I say a wasting disease, night sweats, sputum that's kind of blood. It's like swirls of green mucus and red blood. It's very, very distinctive, as sputums are prone to be in these particular things. So we'll continue on with this. And again, I'll be sending everybody a copy of this, even though it started, this is just all review, and I'm about halfway done with it. That's there. I'm just going strictly on voice rather than utilizing the screen per se to show PowerPoints with this. So we're just doing that. I'm just about ready to start the genitourinary part of this particular presentation, having just finished skin and respiratory, more or less. So as we move on with this, let's continue on. When we start looking at urinary tract infections, by far and away, the classic urinary tract infection is typically caused, and we see it from catheters, we see it from incontinence. Sometimes we see it from hygiene, and most of the time it's E. coli. It's typically a gut bacteria that has either gotten on a catheter or somehow made its way in close proximity. And we see it much more common in women than in men just because of the anatomical differences that are there. So we see E. coli, then we see Proteus, organisms you probably are familiar with from the laboratory. The most common cause, and this is a non-sexually transmitted disease, as is a vaginal yeast infection, which is usually due to powerful antibiotics that have gobbled up something called lactobacillus, and the lactobacillus is what keeps the yeast that's in most oral genital urinary areas as a normal flora, as a normal agent, and allows it to overgrow in that particular area. So, and both of these, like I said, are not, most doctors would advise to be abstinent during those times, but it doesn't necessarily indicate that there would be any problem associated with it. So it's not something you have to take a lot of precautions with, per se. And so we've had the reason I'm stopping, I had a couple of students join, and just want to tell you that I had started this a little bit early to get it all in. And it's the last time you really have to meet, other than tomorrow at 11 when we were doing the exam. And everybody will get a copy of this narrated review session that's there. So please pay attention. I'm trying to give you as many hints as possible with regard to the test. The big problem with sexually transmitted diseases is they are, most of the time, they're very asymptomatic until they're very severe in women, maybe not so much in men that are there. And I think that's a big feature that we have to be understand about those things. That's why they're spread so easily, because a lot of times a subtle amount of drainage or irritation and the usual urinary symptoms like frequency, urgency, burning, I wouldn't say they're ignored, but they're not necessarily, you might dismiss them as being something from any one of a number of problems that might have developed. So I think that's probably the underlying reason, and sometimes people are prone to not be as careful as they should be. And again, we see influence with multiple partners and not using barriers and things like that are there. But we have to look at these diseases, and for most of the drainage ones are the most common are bacterial. Let me rephrase that. The most common are not bacterial, but we'll look at the bacterial ones first. And historically, the most common was gonorrhea, though it's under much better control these days because it's the one that people tend to get treated more because it's the most painful. It's a real distinctive pus producer. It's very painful in the urinary tract, very much irritates the lining. People notice it. So it's, even though less so in women than men, but still a lot, it's caused by a gram-negative diplococci. And all of these effectively work their way up the system, either into the testes or into the ovaries or into the tubes. In women, we call it PID, or pelvic inflammatory disease, infertility, miscarriages, ectopic pregnancies, early onset of need for a hysterectomy. It's awful. That's there. So it's a really significant problem. And again, these are discharge disorders. This one's the most noticeable. It's relatively easy to treat. Even it used to be just penicillin. Now we typically use a combination of penicillins and cephalosporins, and because we're starting to see some resistance, but typically it's a very, again, a very difficult organism to grow in the laboratory, though you can grow it, unlike syphilis, which you can't grow in the lab whatsoever. So this used to be the most common. Now one that's not as painful, and now the most common, the number one bacterial reported STD or STI, sexually transmitted infection, is chlamydia. From Chlamydia trachomatis, the drainage is not as distinctive, but present. It doesn't have that pus-like quality like gonorrhea. It has the typical symptoms that are associated. It's definitely transmitted sexually, but can even be, and most of these is rare with it, other than HPV, to be transmitted non-sexually, coming from fomites or inanimate objects or surfaces. The HPV, then that whole toilet seat thing is a potential that's there. So I urge caution whenever you're not sure. And it has the same laundry list of problems if it gets up into the system. Infertility, it could impact the vas deferens in the testes in the male, the tubes and the ovaries in the women, all of those. The Z-Pak azithromycin or zithromycin, very, very effective, certainly the drug of choice for that. Where syphilis, very easy to find antibiotics for because we can't grow it in the lab. It's extraordinarily fastidious. Even to this day, we can't grow it in the lab. Its name is Treponema pallidum. It's a gram-negative, non-culturable spirochete that's there. It's probably microaerophilic, so it's really we can see it on the microscope, but we can't grow it. Most of the time, you do testing with immune fluorescence to be able to detect it. Everybody was screened for it back for days. I mean, for years rather. To get married, that was the blood test you had to have up until recently, within the last 35, 40 years. I had to have one in 78 when I married for the first time, but not in 2013 as I'm married now. Syphilis there's a certain similarity with Lyme disease, and the fact that they're both spirochetes, very similar, gram-negative, microaerophilic. They go through 3 phases. In syphilis, the first phase is to do with a sore called a chancre or hard canker, spelled chancre. It is a sore on the genitalia. Most of the time, it's external, and women can be internal. You have to be very observant for that. Normally not painful, but noticeable. And it happens within days to weeks after the contact. That's the problem. A lot of times it's a sufficient amount of time that it's not necessarily as notable. The trouble is when that goes away, people are asymptomatic, and there really aren't a lot of symptoms other than sore, maybe some irritation. After that, it goes away until the secondary changes or secondary syphilis occurs. That's when we begin to see a rash, typically palms and soles, feeling lousy. It's called a great masquerader because you have it's all about your immune system. You feel lousy, wasted, you feel like you got mono, you can hardly get out of bed. But the rash on the palms and the soles, and then there's some changes inside the mouth that we begin to see that are quite noticeable. Now, in Lyme disease, you start with that target rash. A lot of times you can't see it because typically that you're bitten by a tick in an area that's a warm, dark, moist area, upper thigh, under the arms. Sometimes you can't see it, even though you might notice it. And again, when that rash goes away, again, you go through a period where it's spreading through your system and your immune response begins to get the characteristic changes of nerve, muscle, and joint pains, and sometimes heart problems. And so there's 3 phases that they go through. And then if it's not treated, you get to potentially permanent damage. In Lyme disease, that happens relatively quickly, 6 to 8 months, if you want to call that quick. But in syphilis, after that secondary, after the initial presentation, the sore, the canker, and then the rash, the secondary presentation, you go through a period of latency. We don't see that in Lyme disease. That latency, even though you can treat it up to a certain point, that can last for 10 years, 20 years, 30 years. So the disease is still contagious, maybe for several years. It still can be treated for a while, but it will typically be asymptomatic until the tertiary changes, damage to the eyes where people can't see, balance, nerve disorders, heart problems. That's when we start to see tertiary syphilis. Sometimes in the old days they called it madness, but it was really damage to the brain from a lot of the problems that were associated with it. So it's very treatable, even maybe halfway between second and third. Not everybody goes to tertiary syphilis, but unfortunately too many did. And that was the reason why they built sanitariums, because syphilis was everywhere. It's really taken a back seat. People are more cognizant of it. They're tested a little more frequently today. But here we worry about, from a viral perspective, HIV. It affects the CD4. That's the name of the marker on that particular white blood cell, that lymphocyte, that forms what are called helper T cells, the single most important cell in your immune system. And when that helper T cell becomes infected, it stops being an effective immune system cell and becomes a factory just to infect more of them. And eventually, when that number of active and successful and useful CD4 cells drops below a critical number, at that point, you make the transition to AIDS and your immune system no longer effectively works. We can see HIV is not as transmissible as you think. It's an enveloped virus. It's not nearly as transmissible as some of the diseases. that are there. So people have to have people who are HIV positive are much less likely to transmit it. Now, someone with AIDS, it's generally in all of their secretions. There's a significant risk with regard to that. Then they look at something called viral load, which you hear a lot about in COVID as to how contagious somebody potentially would be. They're trying to measure by various advanced techniques the number of viruses that are there. Hepatitis is another viral disorder. Hepatitis B is under better control with the immunization. Hepatitis C does not have one. That's certainly the most common type that we see today. That's there. Hepatitis C eventually will lead to liver damage, liver failure, need for liver transplants, or death, cirrhosis of the liver, even though alcohol will be the most common problems associated with it. The other agents that cause significant numbers of STDs are herpes viruses, third most common, Trichomonas vaginalis, second most common, HPV, most common. If you look at all the people who've either had it or have been exposed to it or continue to get it on a regular basis. Trichomonas is interesting because it's a protozoan and we can use metronidazole, which is interesting. We have a great drug of choice. It doesn't give you any immunity, but it'll probably give you 6 months protection. It's very much like chlamydia, not nearly as painful as gonorrhea, has the same risks that are associated with it. Chlamydia and trichomonas used to be called non-specific urethritis or non-vaginal urethritis or non-urethral urethritis, non-gonococcal rather, urethritis. So it works very well because that protozoan is an anaerobe, and metronidazole works great on anaerobic infections. Oh, don't forget that target or bullseye rash for Lyme disease. And that Lyme disease is caused by that spirochete called Borrelia burgdorferi and has all those potential symptoms in the nerve and muscle tract in there. And it's really spread by the tick. The hard chancre for syphilis is important as well. Herpes is another problem. Genital herpes, particularly, the lesions are more painful. They're little blisters. They're not dangerous, but anytime you have drainage, a sore, anything like that, it violates sort of the protective nature of that area. The membrane, the linings, the skin are not there, and therefore you're much more prone to get other infections. So somebody with herpes is more likely to get gonorrhea or get HIV or anything like that, or somebody with HPV, same deal. Okay, so herpes simplex, particularly herpes simplex 2, which is more painful, though 1 and 2 can both do it, are viruses that are associated with this. And if it's an active first-time case for a mom during the birth process in a vaginal birth, these babies can get a life-threatening form of encephalitis. PID, again, that disease that's associated with any time these problems back their way up into the major organs of the reproductive system, ectopic pregnancies, infertility, hysterectomies, all of those things are part of it. I forgot to mention with tuberculosis that you have to use multiple antibiotics and usually rotate them every couple of months for typically 9 to 12 months. Again, the bacterial ones we see with STDs that are so common or have been traditionally, syphilis, gonorrhea, chlamydia. The viral ones, things again like HPV and HIV are part of it. Don't forget about the genetic shift and drift that I had talked about. And another thing with influenza, they utilize immunizations a lot, and they're trivalent. Whether they're of late, they haven't been nearly as effective, but that's a different lecture entirely. Trivalent means when they usually give you 3 different strains that they've chosen, but the thing mutates so fast, they haven't been effective. That's there. Oh, and the other thing about gonorrhea, it particularly leads to joint infections. Gonorrhea is a bacteria whose fimbriae adhere to just about any structure. And if they get into the bloodstream, which they can from the urinary tract, at that point, they tend to adhere to joints. So when we see septic arthritis, pus coming out of a joint where there hasn't been an injury or hasn't been trauma, like someone, fell in the garden and got, splintered deep into their knee or their elbow, at that point, you begin to think about gonorrhea. Okay. And remember the life cycle of Lyme disease. The Lyme disease has to do with the life cycle of the tick. So you don't see it now that it's cold. Those ticks are already on the deer. Good night. Okay. Generally, it's when their season, when they've grown, after they've gone from from their larval stage to their nymph stage. So it's during the summer months. late spring, early fall, mostly during the summer. Okay. And again, tuberculosis is an AIDS-defining illness, just like any one of these others, like Kaposi sarcoma, PCP pneumonia. It means that once you have that on top of HIV, now you have AIDS. Wounds, again, are mostly about staphylococcal organisms. When we have a tetanus-prone wound and you don't have a reliable history, you have to give them the tetanus shot, the immunization. You have to give the immune globulin, so they have the protection right now. And most of the time, they're going to have a pretty bad wound, so you better give them antibiotics. There's a difference between different kinds of gangrene, particularly dry and wet gangrene. Most of the time, the gangrene we see is in diabetics from bad circulation, doesn't involve an organism. The organism that causes gangrene when there's been a lot of significant damage, like a war wound we talked about early in the course, called Clostridium perfringens. That's an anaerobe, and you have to treat that very aggressively. Debridement, metronidazole, hyperbaric oxygen. Burn patients, it's all about Pseudomonas. Pseudomonas is a common soil bacteria. It's in most of our homes because it's in most of the soil, and we bring it in. Common in people who are immunosuppressed. We see it a lot in hospital. We see it a lot in people with burns or damaged skin, called Pseudomonas aeruginosa. So we work with it in the lab, but really significant with regard to burns. I talked a little bit in one of the programs I sent you about necrotizing fasciitis, the flesh-eating bacteria. That's a streptococcal organism, group A beta hemolytic strep. We're seeing it mostly now in people who have injected performance-enhancing drugs, because usually they don't do it under the most sanitary conditions. I've seen a couple of cases. One was in a drug user, but not performance-enhancing, just an IV drug user. It's there. I sent you a lecture about bite wounds. The most common are two that are most animals: dogs, cats, various other animals. Staphylococcus aureus, fortunately a strain that you can treat that isn't one that produces an aggressive penicillinase, and Pasteurella multicoda, which is a small gram-negative. And we use augmentin because the Staph aureus is a beta-lactamase producer, so the augmentin can target that. And the ampicillin that's part of that augmentin can take care of the Pasteurella multicoda. That's there. And again, if they're non-penicillin allergic, it's all about the augmentin. Seems to be the best one for that. Human bite wounds are much more difficult to treat because you have to. They inevitably get infected. They usually have such vast range of bacteria and anaerobes. We usually see it in mostly people who are very combative, and we see that particularly with a mixture of alcohol and amphetamines, more so than anything else. But the most common problem that we see in wound infection is post-operatively, and usually it's Staphylococcus aureus, and typically in a non-penicillin allergic individual, you typically use cephalosporins. And that should pretty much conclude today's review, and I'll be online tomorrow. I'll be sending you an email along with this presentation to give you the instructions on how we're going to be doing the exam via Blackboard and where you can find it. So thanks again. Bye-bye.